We will start with the first bill on the agenda, that is House File 944. Representative Hanson, as a member of the division, you may move your bill. And I believe you also have an author's amendment. Would you like to go ahead and move your bill, please?
Thank you, Chair. I move that House File 944 be recommended for referral to the Human Services Finance and Policy Committee. And I would like to move the A1 amendment, which it includes some mutually agreed upon changes between the advocates and DHS, which will just help us better accomplish the bill's overall intent.
Okay, Representative Hanson moves the A1 author's amendment to put the bill in the shape she would like for its first committee stop. Please unmute. This will be a voice vote. All in favor, please say aye.
Aye. Aye.
Opposed? The motion prevails and the amendment is adopted. Representative Hanson, please go ahead and present your bill as amended.
Thank you, Mr. Chair. Thank you, members of the committee, for hearing this important bill. Each year, 700 children enter voluntary placements through Chapter 260D to receive mental health care at residential treatment facilities. And today's bill essentially treats mental health treatment in a residential facility like it would any other condition or any other level of mental health care. It would be based on medical necessity, and the state would pay for room and board costs for children who otherwise would have used Title IV-E funds. For children in voluntary placements, these Title IV-E funds reimburse counties about $2.1 million. Here's some background. Our children's mental health treatment system has gone through several major changes. In 2001, CMS allowed counties and federal Medicaid dollars to be used to pay for the cost of care for children's residential facilities. The portion of costs associated with mental health treatment that was not covered by federal Medicaid dollars was the responsibility of the county. In a similar way, counties were also responsible for the cost of room and board and sought reimbursement through Title IV-E funds for youth whose families met the program's income requirements. This funding mechanism was negotiated as the state was working to more fully optimize its ability to capture federal dollars through Medicaid. It was a benefit to counties as youth in foster care through the child welfare were always eligible for Medicaid, and this approach helped counties better optimize that federal reimbursement. So since 2009, state and federal Medicaid funds have covered the treatment component of mental health residential placements for children enrolled in the PMAPs, while the counties continue to be responsible for those room and board costs. In 2007, DHS, the state court administration, children's providers, and advocates, they came together and put in the work to develop a new chapter of law, which was 260D. This allowed for voluntary placements for children. This new law made it clear that parents retained decision-making for their child, and that they did not have to go to court, but they still had to file paperwork. This created a separate door, if you will, for families whose children needed treatment due to their mental illness. And this way, it did not feel like the family was going through the child protection door to receive services. And then the Family First bill was passed by Congress in 2018. And essentially, Family First removed that second door and required that everyone go through the child welfare door because we were using child welfare funding. So it's important to note that CMS decided in 2018 that these children facilities were IMDs. So the state couldn't use Medicaid dollars anymore. The legislature then appropriated money to fill in the lost Medicaid dollars. And what we're asking for today is for the state to fill in for the loss of Title IV-E funds so that families don't have to go through the child welfare door to receive the services. Mr. Chair, I'd like to turn it over to Sue Abderholden from NAMI to share more information about why this bill is so important.
Certainly. Thank you, Representative Hanson. Ms. Abderholden, if you'd like to identify yourself and who you're with, please, and start your testimony.
Thank you, Mr. Chairman, members. Sue Abderholden, Executive Director of NAMI, Minnesota. Last year, when the legislature heard the department's bill to implement the Family First legislation, NAMI vigorously opposed it. We did not want parents of children with serious mental illnesses to fully go through the child protection door. And you directed the department to meet with stakeholders to see if there was another way. If Mr. McCall could pull up the small chart that we made. As you can see from the chart, children with mental illnesses access several levels of care through their health plan, looking at medical necessity. So private insurance, PMAP, Medicaid, they look at medical necessity when going to a hospital. Those same plans look at medical necessity when going to a psychiatric residential treatment facility, although I will note that most private insurance right now won't pay for it. Private insurance looks at medical necessity when a child goes into a children's mental health treatment facility. But if it's Medicaid or PMAP, with PMAP, they first look at medical necessity, then it goes through the county child welfare door, as it does with Medicaid. And so you can see that for almost all of the other intensive services, we treat this as medical necessity until we get to a children's mental health treatment facility. You can take the chart down now. Thank you. It doesn't really honestly make sense to me. And I want you to understand how hard it is to be a parent of a child who has intensive mental health needs. It's exhausting. You are trying to keep them from hurting themselves or others. You are desperately trying to find a hospital bed or the right therapist or in-home care. You may have other children and a job, and you feel like you are not able to keep all the balls in the air. Finding intensive in-home services is nearly impossible because honestly, they don't exist. And so then you finally decide, with the help of a mental health professional, that your child needs residential treatment. And then you find out you have to go through child welfare. And honestly, this scares parents. You are so afraid of being judged when you've done the best that you can, but this is extreme parenting. This is not normal parenting. And by the time you reach this point, you are an emotional and physical wreck. And now someone who may not be a mental health professional is going to send a letter out to all of your child's relatives to see if they will care for your child. People you don't necessarily, know are going to gather around a table and decide your child's treatment fate. And honestly, for any of you who are parents out there, none of us would want our parenting judged when we are in a crisis. We are not at our best, but we are doing our best. As Representative Hanson noted, we used to require parents to relinquish custody in order to obtain residential treatment. Then we required them to go through the child protection door. Then we allowed for voluntary placement agreements, so at least you didn't have to go fully through that door. And now we are back at the child protection door, making families who are not found to be abusing or neglecting their children to go through relative searches and large screening teams. We asked families who, honestly, to ask them to come today when they're so stretched during this time, we just asked them, what are your thoughts, frankly, about asking the county or having the county reach out to your relatives? And here's some of the quotes. This is infuriating. Would they ask a relative to care for my child with cancer, heart disease, or diabetes? I would not support this. In our case, we did not have any relatives who could monitor our daughter for self-harm and suicidal attempts 24 hours a day. Absolutely not. The presumption is that the problem is bad parenting skills rather than the child in need of specialized care. Residential treatment is completely different than a sleepover at a relative's house. These kids need professional help, not babysitting. And my favorite comment was, no. It's hard enough to care for and worry about a child with a serious mental illness. I had a child who struggled, well, she's still alive, but I have a child who's, when she was younger, really struggled with depression and anxiety, and it is not an easy path. And so to now have to go through a process that will delay access to care and will frankly serve to humiliate parents by treating them as if they abused or neglected their child is simply something we strongly oppose. We need to treat this as we do other level of intensive treatment as a healthcare issue. If the state or county pays for room and board, families won't have to go through the child protection door. And this bill will do that. It will have children and their families go through the same process as if they were going to a PRTF or a hospital. The door for medical care, not child welfare. Now, we know there are some details that still need to be worked out with MACSA, but the implementation of Family First will take place this September. So we urge your support for the bill, and we promise to work with the counties to see if we can, figure out some of the details. Thank you.
You're welcome. Thank you, Ms. Abderholden, for your testimony. Next person we have is Ms. Andrea Vasquez. If you'd like to identify yourself, who you're with, and start your testimony, please.
Hi, good morning. I'm Andrea Vasquez with Volunteers of America and representing Aspire, Minnesota. a statewide association of children's service providers. Mr. Chair, Madam, and members of the committee, thank you for the opportunity to testify in support of House File 944. This legislation creates an important opportunity to build our children's mental health system around the primary treatment needs of our children and youth. It seems logical to align intensive residential mental health treatment with standards for medical necessity, instead of relying on our child welfare system to screen and fund treatment for children with intensive mental health needs. House File 944 is another building block for Minnesota as we design a system that is responsive to children, youth, and their families. As a seasoned administrator, I have directly seen the many hands that are involved in placing youth in residential treatment. We know that delaying care for children with this level of need can place a child and family in increased risk. Building more efficient systems is undoubtedly in the best interest of children and families. As a clinician, I have seen firsthand the exhaustion, desperation, and hopelessness that families can go through when trying to get their child intensive mental health care. Parents scramble to find available resources and how to access them. I've spent hours with families in tears, with extreme anger, stating how difficult it is to access care. Often what families discover is that they need the support of our child welfare system for their child to receive care, which they cannot understand. What HF944 offers is a path that is more aligned with these family experiences and access to vital care that can provide needed mental health treatment for their child to begin the healing process. With this, I have a couple of families that come to mind. One family whose teenage daughter had experienced trauma at an early age in her home country in Eastern Europe was adopted as a toddler to an American family. The long-term effects of the trauma caused the child to severely act out physically towards her parents, engage in serious self-harm, and was unable to develop secure attachments with loved ones. The family had tried every level of care, including family attachment therapy, to no avail, and the parents were at their wits' end. Children's residential treatment was a recommendation, and their daughter was finally placed in residential care and was able to transition to community life with intensive outpatient services in place after 6 months of care in residential. Another family, a single mother and her teenage son experiencing his first episode of psychosis, came in for an assessment as the youth had grown more and more distant, isolative, and non-responsive to the outside world. This single mother also suffered from mental illness and was significantly struggling to take care of herself and her son, of whom she adored. She worked at a fast food restaurant and could barely make ends meet. After a psychiatric evaluation, it was determined that the young man was experiencing true signs of schizophrenia and that he would need residential treatment to receive further assessment, treatment, and care to stabilize his diagnosis. This young man was able in the end to attend an intensive outpatient program for young adults with first episode psychosis. And with medication and therapy, after 3 months, he was able to receive a lower level of care and return to the community. One final family includes a grandmother and her teenage grandson who had been severely traumatized by the early death of his mother due to a drug overdose. He was very young and shortly after started to exhibit extreme behaviors of aggression at home and at school. The child started to become suspended and eventually expelled from school. The grandmother had a very difficult time attempting to navigate the mental health services and was close to having her own breakdown. She was scared of her own grandson. The school counselor connected the family with outpatient resources, and it was quickly determined that the child needed residential treatment. While in the trusting environment of residential care, the youth was able to begin to understand himself, the root of his negative feelings and aggressive behavior, as well as coping skills to live as a healthy human being in society. Thank you for considering HF 944 and the importance of building a system that honors, responds, and meets these families with the individualized care and treatment that they both need and deserve.
Thank you, Ms. Vasquez, for your testimony. At this point, I'll open it up for questions. Does anyone have questions of our testifiers or of our bill author? Representative Backer.
Thank you, Chair. And then we had some good testifiers, but what I'm looking for is with this bill, to better understand this bill, if I had a child with a mental issue, explain me just street smarts how this bill would help me. You know, I know there's been talk that this will improve this will improve this will help here, here's some concerns here, but as is with no amendments, explain me where this helps to streamline things, because I do agree with the process. This is a very clunky process that we have in Minnesota. So how does this bill help to be less clunky?
Who'd like to attempt that? Ms. Abderholden, if you'd like to go ahead, please.
Thank you, Mr. Chairman. What we hope will happen, Representative Backer, and this is why we need to continue to meet with MAXA, that the child is on Medicaid or PMAP, and it was determined it was medically necessary for the child to go to treatment, they would not go through a county screening process. They would go then directly to the residential treatment. The tricky part comes in is if a child is uninsured, or perhaps their private insurance is only going to pay for a few weeks or something like that. That's the part that we still kind of need to figure out how that would work. Does that help?
Representative Backer, excuse me.
That does help. When you say that there, I'm assuming, and I'm getting a look, so I apologize, Chair. This is heading to what committee next?
My understanding is that the next committee we'll go to will be Human Services.
Okay. So,
our reports go straight to them after we're done with the bill here.
Okay. So thank you. And because I'm like you, if it's clunky here and it isn't clarified, now we got a couple other stops. We got to unclunky it, because as we know, children in that type of scenario and their parents, they need some stability to help to get through the process. And as you work through, I'm foreseeing a potential amendment down the road. You're welcome to share that with me, because I know when we were in majority, you and I worked a lot on these issues. So I would like to see that when it gets closer. I might have some ideas too. So for now, that's what I have. Thank you, Chair, and thank you, ma'am.
You're welcome. Thank you, Representative Baker, for the input and interest in being involved with this bill going forward.
Close. Backer, Chair.
Backer.
Okay.
Thank you. Darn it. I apologize. Okay. Next, we have Representative Frankie. Representative Frankie, if you'd like to go ahead, please.
Thank you, Mr. Chair. Thank you, members. I want to thank Representative Hanson for bringing this bill forward. I have a few questions. I'm glad to see that the amendment fixed several of the concerns that I had about the bill prior to getting the amendment, or even the McCassa letter late last night. I'll just start out by, let's see here. On the amendment, I was wondering if the author could let me know why we're just reinstating the residential treatment facility and not the rest of the explanations on page 2, line 13. I'm glad to see that some of that language was reinstated, but are we just leaving that vague for a reason, just as a whole residential treatment facility, to not like pigeonhole ourselves, or how does that work?
Representative Hanson, would you like to answer that? Or I think I saw Ms. Abderholden's hand go up. Who would like to?
I would like for Sue to answer that. She is very good at explaining the complexities of this. So if it's okay with you, Representative Frankie, I would like to let Sue explain that.
Ms. Abderholden.
Thank you, Mr. Chairman. So right now, counties don't screen for a child to go into acute care hospital. I mean, it's just, that was in the Children's Mental Health Act many years ago, but they don't do that. And we don't really have regional treatment centers anymore, so especially for children. So it seemed like that was kind of archaic language that doesn't really happen. So it seemed, like we should take it out. The one thing I will note is that if a child, young person is going into a chemical dependency facility, they don't go through child welfare screening.
Thank you, Ms. Abderholden. Representative Frankie, further questions?
Thank you, Mr. Chair. Maybe somebody could answer for me. Is this a voluntary placement only situation?
Ms. Abderholden?
Mr. Chairman, yes. Because
Representative Frankie?
otherwise you have to go, I mean, you've already, if a child is, if the family is being accused of neglect or abuse, they're already referred then to the child welfare, and so they're already in that system.
Representative Frankie?
Thank you, Mr. Chair. On to my next question for the author or the testifiers. Why are we deleting in the entire section 4? I noticed some of it may be archaic language, but nothing that I can see was reinstated. So I'm kind of wondering why on the amendment we're deleting the entire section 4.
Mr. Chairman?
Go ahead, Ms. Abderholden.
This was on the advice of the Department of Human Services. They said that the language we had added, the new D, was not needed, that we didn't need that language, and so we deleted section 4 of the bill.
And we also do have the department available for answered questions also. Representative Frankie?
Thank you, Mr. Chair. Thank you, Ms. Abderholden. So what section or what area of the bill should I be referring to then to look to that then replaces or refers to?
Ms. Abderholden, or should I do have?
Mr. Chairman, it will actually be on the in section 6, where we're then saying that if a child is eligible for residential services without a referral from the county, that it can kind of go straight forward that way.
Okay. Representative Frankie?
Thank you, Mr. Chair. I'll check that out. And then on to my next question, Mr. Chair. The amended line, page 6, line 25, where it inserts, except the Commissioner of Human Services or Managed Care Organization retains authority to make determinations related to medical necessity and clinical appropriateness of placement. Does this supersede any parental or custodial rights?
Ms. Abderholden?
Mr. Chairman, Representative Frankie, it should not. That additional language was at the request of the Department of Human Services. Personally, I didn't think we needed it, but they wanted it, and so we put that in. But we just wanted to make sure that it was clear that parents retain legal custody and that they don't give it up.
Okay.
Thank you, Ms. Abderholden. Representative Frankie?
Sounds good. No, I think this is a needed bill. I am wondering about the fiscal impact of this, and how we're going to work this. I'm hoping that, reading this Mikasa letter, that, there are some issues on how these payment structures are all going to intertwine to get this accomplished properly. So I want to make sure that we're getting this done right. When it comes to good policy, we want to make good policy moving forward that is feasible and attainable to, accomplish what we want to get done here for our kids. So I appreciate it. And that's all the questions I have, Mr. Chair. Thank you.
You're welcome. Thank you, Representative Frankie. Ms. Abderholden, you have something you'd like to add?
Yes, Mr. Chairman, if I might, I just want to pledge to the committee that we will work with MAXA. We know we can't come in with a bill that's going to cost $30 million or anything like that. So we will work with them. We do feel, somewhat under a time pressure because this will go into effect in September. I think we all felt, as you can see in Max's letter as well, a little frustrated that we couldn't find a solution before the session started. But I promise you, we will work with them and try to figure this out.
Thank you, Ms. Abderholden. I do not see any further questions. At this point in time, I will turn it over to Representative Hanson for any final words she may have.
Thank you, Mr. Chair. And thank you, members of the committee, for hearing this important bill. I know it is a complex subject, but it is, like Representative Frankie said, very important that we make sure we address this and are helping out these kids and families. So thank you for your time, and I look forward to your support.
You're welcome. There being no further discussion, Representative Hanson renews her motion that House File 944 as amended be recommended for referral to the Human Services Finance and Policy Committee. Mr. Kroos will take the roll.
Fisher.
Fisher, aye.
Fisher, aye. Frederick.
Aye.
Frederick, aye. Frankie.
Aye.
Frankie, aye. Backer.
Backer, aye.
Backer, aye. Baker.
Baker, aye.
Baker, aye. Becker Finn.
Aye.
Becker Finn, aye. Hanson.
Hanson, aye.
Hanson, aye. Katiza Wattoon.
Aye.
Katiza Wattoon, aye. Lippert.
Lippert, aye.
Lippert, aye. Moeller.
Aye.
Moeller, aye. Pearson.
Pearson, aye.
Pearson, aye. Thompson.
Thompson, aye.
Thompson, aye. In 12 ayes and 0 nays, the motion prevails.
The motion with 12 ayes, 0 nays, the motion prevails. House File 944 as amended is recommended for referral to the Human Service Finance and Policy Committee. Thank you, Representative Hanson.